It's a pleasure to be with you. The title of this session is Organization and Financing of Public Health, Part 10, Local Public Health. There are no disclosures for this presentation. Objectives include review key points of federal and state health department roles in public health, review key attributes of local public health departments in the United States, discuss the governance classifications for state and local public health departments, discuss the variations and roles of local boards of health, review local public health workforce attributes. In the last 7 sessions, we've reviewed the federal government's and state health departments' roles in the practice of public health. Let's review a few key points from those sessions. Federal departments involved in important aspects of public health include the Department of Health and Human Services, DHHS, Department of Agriculture, USDA, Environmental Protection Agency, EPA, Department of Labor, DOL, and Departments of Veterans Affairs, VA, and Defense, DoD. Each one participates in some aspect of the 10 essential public health services designed to promote equitable access to conditions that promote public health. DHHS is the main government public health agency. Within DHHS, the CDC is the principal division that produces evidence-based public health information and communicates it to the public and to public health and healthcare professionals. Other DHHS divisions of special importance to public health are the Administration for Children and Families, ACF, Health Resources and Services Administration, HRSA, Centers for Medicare and Medicaid Services, CMS, Food and Drug Administration, FDA, and National Institutes of Health, NIH. Key points regarding state public health include state public health is comprehensive yet inconsistent, with state public health organizational structures and services provided varying from state to state. State public health funding and administrative decisions generally rest with the legislature or executive branch of state government. The relationship between state health departments and local departments exhibits considerable variation: decentralized, centralized, mixed, and shared. Common services provided by state public health departments include surveillance and epidemiology, environmental health, maternal and child health, emergency preparedness, immunization services, regulation, inspection and licensing, vital records, and personal health care. Most of the services provided by state health departments, like that of the federal government, fall under the 10 essential public health service categories. A major role for federal and state public health agencies and programs is to provide support for the implementation and delivery of public health programs and services at the local level. Let's now discuss local public health for a few minutes. Most public health services in the United States are provided through city, county, or regional local health departments and represent the front line of communicable and non-communicable disease control and community public health education. Local public health depends on the support of state and federal public health agencies, their resources, including data, skilled personnel, funds, etc. In most states, The state and local public health agencies collaborate closely. So even though the state health department may not provide many direct services, state health departments provide essential support to local health departments to carry out essential public health services under their jurisdictions. The National Association of County and City Health Officials, NACHO, is the only organization dedicated to serving local health departments. NACHO defines a local health department as administrative or service units of local or state government concerned with health and carrying some responsibility for the health of a jurisdiction smaller than the state. There are significant variations between local health departments. It's often said that if you've seen one local health department, you've seen one local health department. They differ between states and within states on organization, governance, service provided, and implementation strategies. As might be expected, a major factor driving variation is the size of the population served. There are approximately 2,800 total local health departments in the United States. 61% of local health departments serve jurisdictions with 50,000 or fewer people, and 39% of local health departments serve jurisdictions with fewer than 25,000 people. Local health departments serving large urban centers with populations greater than 500,000 constitute only 6% of U.S. local health departments, yet serve 52% of the United States population. The organization and governance structure of local health departments is classified according to their relationship with the state health department. Local public health in the United States is organized in four ways: decentralized, or led by local governments; centralized, or those run by the state; mixed, where there are some units run by the state and others by local governments; and shared, where all local health departments are governed by both state and local stakeholders through a joint board. This chart shows local public health governance types across the United States. In 2019, 30 states were decentralized. All local health departments in Florida, Georgia, and Kentucky had shared governance. All local health departments in Arkansas, Delaware, Hawaii, Mississippi, New Mexico, and South Carolina were centralized as part of the state health department. Rhode Island has no local health departments. The remaining 10 states had a mixed governance structure. Another factor differentiating local health departments is whether there is an associated board of health. Overall, 30% of local health departments had no board of health, with 20% having an advisory board and 50% a governing board. Regarding population served, up to 500,000 population, the percents essentially followed the overall numbers. With a population of 500,000 plus, 43% had no health board, but when they had a board, it was likely a governing board, 38%. For centralized governance systems, 58% had no board, 33% an advisory board, and 9% a governing board. For decentralized systems, 19% had no board, but when they had a board, it was most likely governing, 63%. For shared governance systems, 48% had no board, but when they had a board, was likely a governing board, 41%. The general functions of boards of health can include oversight, a function of 75% of public health boards; policy development, 66%; legal authority 61%, continuous improvement 47%, resource stewardship 49%, and partner engagement 47%. Oversight authority entails ultimate responsibility for performance and includes hiring and firing the public health director. Policy development includes ensuring that policies are consistent with laws and rules. Legal authority includes adopting public health regulations and imposing or enforcing quarantine or isolation orders. Continuous improvement relates to the gathering of quality improvement and performance data and using that to improve department performance. Resource stewardship may include approving the local health department budget, setting and imposing fees, imposing taxes for public health, and requesting a public health levy. Partner engagement includes strengthening community partnerships, collaborations, and relationships, since public health at all levels requires solid collaborations and partnerships to achieve its goals. Public health partnerships and collaborations include healthcare systems, colleges and universities, K through 12 school systems, local businesses, nonprofit community organizations, and other government agencies. These external relationships increase the visibility and extend the resources of local health departments, improving their effectiveness. There was a decline in external partnerships of all kinds between 2008 and 2016, which quickly rose after that period. According to a Harvard Business Review article, this seemed to be a byproduct of the Great Recession, when organizations had to rewire operations, reallocate resources, and in some cases, reinvent business models to make it through the downturn and return to growth. This graph summarizes the most common fiscal or resource responsibilities of local boards of health. Over 50% of local health boards oversee budgets, funding sources, service fees, and approve grant applications. This table provides a more granular look at local board responsibilities developed by the National Association of Local Boards of Health. 93.5% of local boards review public health regulations. 88.7% recommend public health policies. 88.5% recommend community public health priorities. 87.7% recommend health department priorities. 86.8% propose public health regulations. 86.6% collaborate with the health department for strategic planning. 85.6% collaborate with the health department to establish priorities. 83.3% ensure that a community health assessment is completed, which is often done in collaboration with academic centers or external consultants. 82.5% revise public health regulations, and 82.3% establish community public health priorities. The workforce is the heart and soul of any organization, and public health is no exception. And there are some concerning trends regarding the public health workforce. Local health department FTEs decreased from 166,000 in 2008 to 136,000 in 2019, a 16% decrease. At the same time, the U.S. population increased by 8%. A decrease in registered nurses is particularly significant since nurses play a critical role in the public health workforce, particularly in small and medium health departments. the number of registered nurses in public health declined from 33,200 in 2008 to 21,200 in 2019, a 36% drop. Barriers to hiring and retaining public health nurses include the geographic location of smaller rural health departments and non-competitive pay. The shortage of nurses affects many clinical services provided by local health departments, like immunizations, maternal and child health services, and screening programs for high blood pressure, diabetes, blood lead, and communicable diseases. 94% of local public health directors are full-time employees, with 49% having a master's degree, 29% a bachelor's degree, and 14% a doctorate. 56% of directors with doctoral degrees are found in health departments serving 500,000 people or more. 6 to 9% of directors have a medical degree. 31% of more experienced directors have an advanced public health degree. 2/3 of local public health directors are female, and that is trending upward. Fewer than 10% of public health directors are a race other than white. 2/3 of these health executives are 50 or older, and 1/4 are 60 or older. 11% are younger than 40. Since 2008, the proportion of top executives, both older, 60 plus, and younger, less than 50, has grown. The largest proportion of the public health workforce is administrative or clerical, 23,100 FTEs, 17% of the workforce, followed by environmental health workers, 14,500 FTEs, 11% of the workforce, and business and financial operations staff, 8,900 FTEs, 7% of the workforce. The median number of FTEs in a U.S. local health department is 17, ranging from a median of 6 for departments serving a population of fewer than 25,000 people to a median of 456 FTEs for departments serving more than 1 million people. The composition of each local health department's workforce varies by size of the population served. The smallest departments, serving populations less than 10,000 people, may only consist of a 0.9 FTE public health director, 1 clerical staff worker, and 1 registered nurse. For health units serving 10,000 to 24,999 people, staff may consist of 1 director, 2 registered nurses, 2 clerical staff, and 1 environmental specialist. For units covering 25,000 to 49,999 people, staff may include 1 director, 3.8 registered nurses, 3 clerical staff, 1.4 environmental specialists, 0.6 health educators, 0.5 preparedness staff, and 0.2 nutritionists. Above populations of 100,000, various staff are added, including an epidemiologist, public health physician, community health workers, information systems specialist, public information officer, licensed practical nurse, laboratory technician, and behavioral health worker. 61% of local health departments serve jurisdictions serving populations under 50,000 people, and 39% of local health departments serve jurisdictions with fewer than 25,000 people. As previously mentioned, most public health services in the United States are provided through city, county, or regional local health departments. NACCHO compiled a list of the 10 most common clinical services provided by local public health departments across the United States. 88% of local public health departments provide adult and child immunizations. 86% of local health departments screen for tuberculosis. 70% for other than HIV/AIDS STDs. 62% for HIV/AIDS. 56% for high blood pressure, and 52% for body mass index BMI. 83% provide treatment for tuberculosis, and 52% for other STDs. 68% provide women, infant, and children's WIC services. These clinical services underline the importance of registered nurses in local public health departments, both small and large. For non-clinical population-based services and programs, the most common provided by local health departments are listed on this table. Under epidemiology and surveillance, 90% of local health departments provided services and programs for communicable and infectious diseases. 84% for environmental health, 70% for maternal and child health, and 65% for syndromic surveillance. Under primary prevention, 78% of local health departments provided tobacco prevention programs and services, 75% for nutrition, and 60% for chronic diseases. Under regulation, inspection, and licensing, 78% provided food service establishment inspection services, 72% for school and daycare centers, and 68% for septic systems. Under other environmental services, 78% provided services for food safety inspection and 72% for public health nuisance abatement. The availability of the clinical and population-based services varies with the size of the population served. Not surprisingly, larger local health departments offer much more than small units. Even if local health departments do not provide some of these services, it does not necessarily indicate that those services are not publicly available for a community, since they may be provided through another local government agency, the state health department, or a nonprofit organization. In summary, a major role for federal and state public health is to provide support for the implementation and delivery of public health programs and services at the local level. There are significant variations between local health departments. 61% of local health departments serve jurisdictions with 50,000 or fewer people. 50% of local health departments have a governing board of health. Oversight is a function of 75% of local public health boards. Over 50% of local health boards oversee budgets, funding sources, service fees, and approve grant applications. The number of registered nurses in public health declined 36% from 2008 to 2019. Common local public health clinical services underline the importance of registered nurses in local public health departments.